Good morning, and thank you for joining us here in Chicago and online for today's News of the Day press briefing. I'm Dr. Julie Graylow, ASCO's Chief Medical Officer and Executive Vice President and moderator of today's briefing. I'm pleased to welcome 4 presenters who will provide new insights into the treatment of colorectal cancer, Ewing sarcoma, breast cancer, and multiple myeloma. These abstracts will all be featured in today's plenary session. As a reminder, the embargo on these studies lifted this morning already at 7 a.m. Central, 8 a.m. Eastern Time. Also joining us on the stage are ASCO experts Dr. Kathy Ng and Dr. Jane Meisel, who will provide expert content about the studies that are being highlighted today. Excuse me. For all of us, we ask that you please use our ASCO affiliations for the purposes of attribution in the meeting coverage. Our first presentation will detail the findings of a phase 3 prospective trial comparing panitumumab and bevacizumab in combination with standard doublet first-line chemotherapy for patients with RAS wild-type metastatic colorectal cancer. The lead study author, Dr. Kakeyuki Yoshino, is the chief of the Department of Gastrointestinal Oncology and deputy director of the National Cancer Center Hospital East in Kashiwa, Japan, and he will present the findings. Dr. Yoshino? You can move it forward.
Okay, thank you. Okay, thank you very much. First of all, I want to say it's a great honor and a privilege for me to be given the chance to this the ASCO honorable plenary session. My name is Takayuki Yoshino, a medical oncologist basis, National Cancer Center Hospital East in Japan. I already introduced my presentation talking about the panitumumab versus bev in combination with the standard chemo modified FOLFOX6 patient in the first-line setting and patient with RAS wild-type metastatic colorectal cancer. So, background information that the colorectal cancer is the third common diagnosed cancer worldwide, and estimate 2 million new case diagnosis 2020. So about the 36% of the colorectal cancer patient had metastatic disease at diagnosis. So addition of the anti-EGFR or the anti-VEGFR monoclonal antibody to standard chemotherapy improve overall survival of patients with metastatic colorectal cancer up to median overall survival of the 30 months. So cumulative retrospective evidence suggests that longer overall survival with the anti-EGFR antibody over anti-VEGF antibody, bevacizumab, in patients with RAS wild type and the primary tumor, left-sided tumor, defined as a descending colon, sigmoid colon, rectosigmoid, and the rectum. So approximately 35% of the metastatic colorectal cancer. Nevertheless, both anti-EGFR, VEGFR antibody are used in patients with RAS wild type, left-sided tumor, which warrants prospective comparison in this refined population. Now, please keep in mind, US in the United States, both anti-EGFR, VEGFR was used. So, Paradigm is the first prospective study to test the superiority of panitumumab versus over bevacizumab plus standard chemo for patients with RAS wild-type patient. So this is the trial scheme. You can see patients with RAS wild-type patient, RAS wild-type metastatic colorectal cancer were randomized in a 1-to-1 ratio comparing panitumumab versus bev in combination with the same modified FOLFOX6 until disease progression, patient withdrawal, intolerant, toxicity, and the curative resection. The primary endpoint is that left-sided population OS. If the significant hierarchical way, we analyze, moving forward to analyze OS in the overall population defined as both left-sided and right-sided population. So here is the most important slide in my presentation, left-sided particularly. You can see OS in the left-sided population, you can see with a hazard ratio 0.82, p-value 0.031. If the p-value 0.04202 less than, So we will consider as significant. So we move forward to the second primary endpoint analysis, OS, in the overall population. You can see similar message brought forward in this patient population. Looking at the median left side once again, you can see more than 3 years overall survival in panitumumab plus modified FOLFOX7, 37.9 months. It's never reported previously. So in conclusion in this presentation that phase 3 paradigm study met primary endpoint 1 and 2 both. They demonstrated the superiority of the panitumumab over bevacizumab in combination with the modified FOLFOX6 in both left-sided overall population both. You can see here the median value overall survival, the 37.2 months favoring panitumumab in left-sided population, 36.2 months in overall population. So proceeded more than 3 years in both populations. So panitumumab and the modified FOLFOX6 demonstrated longer survival ever reported in the first-line metastatic colorectal cancer phase 3 setting. So in conclusion, in this presentation, these results established standard first-line combination regimen for patients with RAS wild-type left-sided metastatic colorectal cancer. So currently, the multi-omics analysis ongoing, some data already finished. You can see here note, 92% of the plasma tissue pre-treatment already utilized. Now you can see here right at the bottom, as post-treatment, you can see here 76% of the plasma also be collected, and also 161, which is a number, old number, who conducted the conversion surgery at the curative intent already collected. These are analysis shown here, middle, white box. You can see tissue plasma DNA sequencing, of course, the RNA sequencing, signature analysis, multiple immunofluorescence analysis with artificial intelligence. These results also be available in the future upcoming international meeting. So thank you very much for kind attention.
Thank you very much. Now we are going to have just a little expert comment on that before. So if you can have a seat and be comfortable. So now Dr. Kathy Eng will make a few additional comments about the significance of this research.
So I think it's really important to keep in mind for our patients with surgically unresectable disease, the expected 5-year survival is still only at 15%, and it's only changed about 6% over the past 20 years. We are constantly looking for new breakthroughs, and this is one of the longest overall survivals that have been reported. The median follow-up is extremely long. It's 61 months, if I'm correct. Granted, this is specifically for the left side, but also it's been an area of controversy, especially here in the United States, because we have not necessarily had a prospective trial. We have looked at several of our other trials that were not specifically powered for the left-sided tumors. So this adds quite a bit to the literature, and I think we're quite excited about the possibilities of increasing the survival of our stage 4 patients.
Thank you very much, Dr. Eng. Next, we will invite to the stage Dr. Mrd McCabe. He is a clinical senior lecturer in pediatric and adolescent oncology at the University of Manchester in the United Kingdom. Dr. McCabe will present the results of a phase 3 trial addressing different chemotherapy regimens in patients with recurrent and Ewing sarcoma, the first randomized trial in this patient group. Dr. McCabe.
Thank you. Again, I'd like to thank the organisers for giving me the opportunity to present these data in a very rare cancer from a very extensive international collaboration. So I'll be talking about the phase 3 comparison between this cyclophosphamide topotecan arm and the high-dose ifosfamide Inrica, and I present this on behalf of the trial management group, most of whom are named here. So for some background, Ewing sarcoma is a very rare cancer of bone and soft tissues that predominantly affects children and young adults, particularly in the second decade of life. So the incidence rate is 3.2 per million under 25-year-olds. 5-year survival for the disease overall is about 50 to 60%, although there are good and poor prognosis groups within that. For patients where the disease has either progressed on first-line treatment or recurred after treatment, survival is very poor, under 15% at 5 years. And over the years, actually multiple chemotherapy regimens have evolved, and even within those regimens, multiple variations of the dosing schedule. But before we opened the RECUR trial in 2014, the evidence was very poor. There were no randomized trials. There was no consensus on which was the best regimen to treat patients or which we should use as a chemotherapy backbone to test novel agents. So on the top left is the trial design. We initially had a 4-way randomization, and patients could be entered into any 2, 3, or 4 arms, depending on their eligibility. It was a multi-arm, multi-stage, adaptive, simultaneous phase 2-3 trial with a Bayesian analysis. And this trial design is an extremely economical way of studying multiple regimens in as few patients as quickly as possible. The primary outcome was event-free survival, and we evaluated multiple secondary outcomes, but the outcomes I will be presenting today are listed here. The drug regimens are shown on the top right. I'm sorry, the formatting has gone a bit wrong for that slide. And the 2 regimens in the phase 3 comparison are in blue. We made a pragmatic decision to drop 2 arms quickly after 50 and 75 patients had been recruited to each arm, however little the difference, based on the primary outcome but taking account of secondary outcomes. And before we opened the study, given that there were really no good evidence at all in this disease, we agreed that if in the phase 3 comparison, if we showed with 70% probability that one arm was better than the other, that would be adequate to take forward as the standard arm. So showing the primary results, the event-free survival, you can see on the left the survival curve for topotecan cyclophosphamide in blue and for ifosfamide in red. Given the observed data, there was a 96% probability that ifosfamide was better than topocyclo for event-free survival. I just should add that the numbers beyond about 6 months are extremely small, so most of the events and therefore most of the analysis was on the left-hand side of the curve. This equated to a 2-month difference in median survival, so 3.5 months for topocyclo and 5.7 months for ifosfamide, and a 10% difference in event-free survival at 6 months. I'll show here the curve for overall survival. Again, please note the very small numbers beyond about 2 years. So most of the deaths were in the early phase of the survival curve. Again, given the observed data, there was a 94% probability that ifosfamide was better than topotecan cyclophosphamide, and this equated to a 5-month difference in median survival, and again a 10% difference in 1-year overall survival, which was also present at 2 years. So to draw some conclusions, just given the time constraints, I haven't been able to present data on toxicity, etc., but I'll refer to them here. So I say again, this is the first ever randomized controlled trial of chemotherapy in this disease setting. It's been a huge collaboration, and in the phase 2 comparison, we showed that ifosfamide was more effective at prolonging EFS and OS than topocyclo. I haven't been able to show it here, but I will present later. The benefits of ifosfamide are more obvious in children under 14. In terms of toxicity, the regimens were similar in terms of the rate of neutropenic infection. Not unexpectedly, ifosfamide caused more renal toxicity and more encephalopathy than topocyclo, with the frequency of those toxicities being less than 10%. We previously showed that the 2 arms that were dropped were unlikely to be more effective than either of the phase 3 arms, but there are still unanswered questions. Importantly, we now have data that we can use both to inform patients but also to develop future studies. And I should also point out that although we've shown that ifosfamide is better than topocyclo, which is better than irinotecan temozolomide, the differences are quite subtle, and what we actually need is better drugs to cure more patients. Just a very quick acknowledgement to the enormous number of investigators and clinicians who've helped in the trial management group and our funders. Thank you.
Thank you, Dr. McCabe. Our ASCO expert on this study, Dr. Vicky Keaty, provided additional comments about the significance of the research in the press release. She's currently presenting in another session at the meeting, but she'll be available for interviews in the press room beginning at 9:30. Please connect with the ASCO staff in the press room if you'd like to speak with her. Just a summary of what she has said. I think one of the most important points of this important RECUR study is that when you have a rare disease where randomized studies have not been able to be done if we do them in isolated settings. We get multiple regimens that show efficacy, but an inability to compare across the regimens. And so in this really terrific collaboration of multiple sites in Europe, Australia, New Zealand, and across the globe, there was an agreement to test all these regimens that were commonly in use. And so we now have data on efficacy and toxicity, and I think that pediatricians and oncologists are better able to talk about the risks and benefits with high-dose ifosfamide, having superiority, but more toxicity as well. And I understand you're going on and doing some additional testing against another regimen as well. So I think this is just a really important concept. We have rare diseases. If we all work together, we actually can still study them and get answers. So our next presentation is going to discuss the findings of a randomized phase 3 study comparing trastuzumab deruxtecan with a treatment of physician's choice in HER2-low, unresectable, or metastatic breast cancer. I'd like to invite Dr. Shanu Modi, a medical oncologist at Memorial Sloan Kettering Cancer Center in New York, to present the results.
Thank you. I echo the other speakers and the opportunity to present our data. I am presenting on behalf of my co-investigators from the DESTINY-Breast04 trial. It's a global study, and it's an honor to present the first results from the randomized phase 3 trial of trastuzumab deruxtecan, which is a HER2 antibody drug conjugate, versus the treatment of physician's choice in patients with HER2-low metastatic breast cancer. So we currently define the HER2 status of breast cancers in a binary model, where HER2-positive breast cancers driven by the oncogene are treatable with currently available HER2-targeted therapies. HER2-negative breast cancers are not. However, within the HER2 population, there are tumors that have low levels of HER2 expression, which we have termed HER2-low breast cancer, for which this HER2 receptor may still be targetable. Our currently available therapies, however, or HER2-targeted therapies, have not proven effective for patients in this subgroup. We currently treat these HER2-low breast cancer patients as HER2-negative breast cancer, where therapy is really guided by hormone receptor status. And ultimately, once we've exhausted endocrine therapies and the few lines of targeted agents, we really have limited late-line options for these patients, most commonly offering palliative single-agent chemotherapy, and this has very modest activity, so we really have a big unmet need for more effective therapies. So trastuzumab deruxtecan, called TDXD, is a next-generation HER2-targeted antibody drug conjugate, and by virtue of its unique properties and mechanism of action, in particular the bystander effect, it has activity across a broad range of HER2 expression in tumors. And in our own proof of principle phase 1 trial, we've previously reported promising efficacy for TDXD in patients with heavily pretreated HER2-low breast cancer. So this really set the stage for the DESTINY-Breast04 trial, which is the first randomized phase 3 study of trastuzumab deruxtecan in patients with HER2-low metastatic breast cancer. This was an open-label, multi-center, multi-nation trial. We enrolled patients with centrally confirmed HER2-low breast cancer who had previously received 1 or 2 lines of chemotherapy in the metastatic setting. In addition, patients with hormone-positive breast cancer were required to have endocrine refractory disease. We defined HER2-low by IHC scores of 1+ or 2+ without gene amplification using the ASCO CAP guidelines. Randomization was 2-to-1, and TDXD was given at the approved dose. The physician's choice of chemotherapy options included capecitabine, eribulin, gemcitabine, paclitaxel, and nab-paclitaxel, and they were administered per the local label. I should go back for 1 sec. The primary endpoint of DESTINY-Breast01 was progression-free survival in the patients with hormone-positive HER2-low breast cancer. Key secondary endpoints were progression-free survival for all patients and overall survival for the hormone receptor-positive patients and all patients on the study. We plan to enroll 540 patients, approximately 480 hormone-positive patients, and 60 hormone receptor-negative patients to reflect the natural prevalence of these receptor subtypes seen in the HER2-low population. And now here are the results. So starting with progression-free survival, I'm showing you here the PFS curves for the entire study population. The PFS hazard ratio was 0.5 with a p-value less than 0.0001. This translates to an improvement in median progression-free survival from 5.1 months with chemotherapy to 9.9 months with T-DXd. These results were similar to the findings for the hormone receptor positive cohort and also the exploratory hormone receptor negative cohort. Overall survival was a key secondary endpoint, and these are the curves again for the entire study population. The OS hazard ratio is 0.64 with a significant p-value of 0.001. The median overall survival improved from 16.8 months with standard chemotherapy to 23.4 months with T-DXd, which is a 6.6-month gain in survival. To summarize, DESTINY-Breast04 met its primary and secondary endpoints. T-DXd is the first HER2-targeted therapy to demonstrate statistically significant and clinically meaningful improvements in progression-free survival and overall survival compared to standard chemotherapy for patients with HER2-low metastatic breast cancer. The benefits of T-DXd were seen across subgroups, including the hormone receptor positive and negative patients and the IHC 1+ and 2+ breast cancers. I will present more data about toxicity at the full meeting, but we know, or we acknowledge, that lung toxicity is an important toxicity of T-DXd. In the DESTINY-Breast04 trial, we saw lung toxicity in 12% of patients, including a 0.8% incidence of grade 5 events with 3 reported deaths, highlighting the importance of awareness and close monitoring of patients to prevent the serious toxicity. The safety profile of T-DXd in general was consistent with what we have seen in other trials. Overall, these results establish HER2-low metastatic breast cancer is a targetable population of breast cancer with trastuzumab deruxtecan as a new standard of care in this setting. Thank you.
Thank you. Thank you, Dr. Modi. I'd now like to invite our ASCO expert, content expert, Dr. Jane Meisel, to provide a few additional comments on this study.
Sure. No, what an exciting study to be able to comment on, and congratulations on this amazing work. You know, I think the results of this trial clearly will be practice-changing. As breast oncologists, we've seen trastuzumab deruxtecan rapidly incorporated now as early as second line for patients traditionally defined as HER2 positive. And everyone who's used it in our clinic undoubtedly has seen some patients, even with significant burdens of disease, have their cancer melt away with this agent. And I think what this trial does is really extend the benefits of this agent to a whole new group of patients that traditionally is really quite difficult to treat. Our endocrine refractory, ER-positive patients, triple-negative patients who have progressed on 1 or 2 lines of therapy, and are HER2-low. Now they can potentially benefit from this drug, which we've seen improves both progression-free and overall survival in clinically and statistically meaningful ways. So I think this will offer a wonderful new option for patients, and also will really fundamentally change the way we think about HER2 status and how we classify this in our metastatic patients. So this is really just a huge win for our patients and for the oncology community.
Absolutely. Congratulations on the study. We're going to have to change the way we report pathology for breast cancer now as a result of this study. So thank you, Dr. Meisel. Our final presentation today will highlight the results of a phase 3 study of lenalidomide, bortezomib, and dexamethasone with or without autologous stem cell transplantation and lenalidomide maintenance until progression for newly diagnosed patients with multiple myeloma. Dr. Paul Richardson, the clinical program leader and director of clinical research at the Jerome Lipper Multiple Myeloma Center at the Dana-Farber Cancer Institute in Boston, will present the findings.
Great. Thank you very much, Julie. It's my pleasure to present on behalf of my investigators the results of the primary data from our phase 3 determination trial, in which we sought to evaluate the impact of lenalidomide, bortezomib, and dexamethasone, which we call RVD, with either early transplant or delayed or deferred transplant, and very importantly, lenalidomide maintenance until progression for newly diagnosed myeloma patients aged 65 years and younger. I especially want to acknowledge my co-investigators across 56 centers in the United States, as well as the support of the Clinical Trials Network, and in particular also the support of the Alliance. The background to the determination study is summarized as follows. Does the addition of high-dose melphalan plus a stem cell transplant improve outcomes for patients with newly diagnosed disease receiving novel triplet induction therapy combining lenalidomide and immunomodulatory drug, bortezomib, a proteasome inhibitor, and of course our backbone of dexamethasone integrated into this triplet? And most importantly, does lenalidomide maintenance, which is an oral therapy given until disease progression, improve outcome? Now, we recognize that high-dose melphalan with autologous stem cell transplant is indeed a standard of care for newly diagnosed patients. And what we found is that the triplet induction regimens, including RVD, are not only highly efficacious with deep rates of deep response and prolonged clinical benefit, but when combined with long-term maintenance therapy with lenalidomide, we have evidence that this prolongs disease control and, in fact, in the transplant setting, improves survival. So given this, the question that we were asking is how much does autologous stem cell transplant enhance the efficacy in newly diagnosed transplant-eligible patients, and can its use be tailored? Can it be delayed or kept in reserve for selected patients? So this is the study design and patient disposition. We gave it the acronym determination. It's a little bit loose, so I apologize for that, but nonetheless, I think you can see what we're driving at. And at the same time, we gave initial treatment with RVD for 1 cycle. We actually enrolled into the study and treated 729 patients. 722 patients were randomized. Stratification was by ISS disease stage, which was our classical staging system at that time, approximately 12 years ago. And cytogenetic risk was equally important in our assessment of stratification. Each cycle of the triplet is based upon lenalidomide maintenance, 25 milligrams of lenalidomide administered 2 weeks on with bortezomib given in a classical fashion and dexamethasone partnered with our bortezomib. Now, Arm A was our RVD alone arm. 357 patients were randomized to this, and we gave basically here up to 8 cycles of RVD all told. But before we collected stem cells, we gave 3 cycles of RVD, and then proceeded to a total of 8 cycles, followed then by lenalidomide maintenance. Arm B did exactly the same thing, but critically integrated high-dose melphalan, 200 milligrams per meter squared, with autologous stem cell support, and a total of 5 cycles of RVD. And as mentioned, this induction and plus or minus transplant consolidation treatment lasted about 6 months, and then we proceeded to lenalidomide maintenance until disease progression. Now, we started lenalidomide maintenance at 10 milligrams daily for the first 3 months, and if tolerance was confirmed, we increased it to 15 milligrams per day. Our primary endpoint was progression-free survival, and our key secondary endpoints were overall survival, duration of response, time to response, quality of life, and safety. So what are our key findings? Well, for efficacy, what we were able to demonstrate was that there was a highly significant improvement in progression-free survival with the use of early autologous stem cell transplant. And what we saw here was that the estimated proportion of patients disease-free after 5 years was almost 56% for those receiving transplant versus approximately 42% for RVD alone. What's important to understand is that in terms of actual duration of median progression-free survival, it was therefore approximately 67 months for transplant and approximately 46 months for the non-transplant or delayed transplant arm. What was very interesting, however, was that the overall survival was exactly the same, at 81% for the RVD plus autologous transplant, and for the RVD alone with transplant kept in reserve, with median follow-up now in excess of 6.5 years, we saw 80% approximately in the same for the RVD alone. So with follow-up approaching a median of 76 months, we have real maturity in this data. And what was also very interesting to us was that of the delayed transplant arm, actually 28% of the patients received this, with other patients being treated with next-generation novel agents and, most importantly, novel monoclonal antibodies. What was also interesting was similar response rates between the arms, but what's very important to note is the addition of high-dose melphalan and autologous stem cell support did dramatically improve duration of response. Now, what was also interesting was our Mrd negative rates. This is a very important marker for us pathobiologically and has, we believe, prognostic importance. Essentially, here we were able to show that with transplant, you achieved Mrd negativity in approximately 54%, and for those patients receiving RVD alone with transplant deferred, it was approximately 40%. And what was particularly important for our patients is that if you achieved Mrd negative status, you did just as well, regardless of what treatment you got. Now, what about tolerability and side effects of treatment? Well, in this regard, we were able to show that, much as expected, there were significant treatment-related side effects with the use of transplant, including mucositis, fatigue, and infections. And of course, this was statistically significantly greater in the transplant early group versus those who were delayed transplant. We also comprehensively evaluated quality of life. We had excellent compliance in our patients, and what we were able to show is there was a significant drop in quality of life across the transplant procedure, and this was by a drop of more than 10 points, which on a QOL score is considered highly meaningful. The good news, though, is that this was recoverable rapidly and was followed by improvements from baseline throughout maintenance. Now, what was also critical to us is there is evidence both from melphalan and indeed lenalidomide that there is an incidence of secondary cancers. So this was a key toxicity outcome that we monitored carefully. We were able to show that there was no overall difference in the rate of secondary cancers between the arms. However, we did see a higher incidence of acute myeloid leukemia and myelodysplastic syndrome with the use of transplant, and this is summarized in the data shown to the right. So the implications, our findings confirm progression-free survival benefit to patients using transplant in their first line of therapy for myeloma and confirms autologous stem cell transplant as a standard of care in the setting of triplet therapy. We also demonstrate the clinical benefit clearly of lenalidomide maintenance until progression. We had a partner trial with our colleagues in France, the IFM, and in their study, which was identical to ours but had only 1 year of lenalidomide maintenance, we improved outcome in both arms highly significantly. Thus, we were able to say that the use of lenalidomide maintenance therapy until progression is now a standard of care. Our results clearly, however, provide support for personalized treatment approaches. And what I mean by that is, if we do not see benefit in overall survival, and you can reasonably delay transplant and use it in a tailored fashion, you can have an equally efficacious outcome in terms of overall survival. So this gives patients that option. And it reflects also the efficacious use of novel therapies at relapse. And I think very importantly, we have real prospective multi-center national data on comparative toxicity. And I think that's very important in informing our patients and providers and providing our patients with choice as they move forward with their treatment plans. Furthermore, it's very important to frame where we are now. We designed this study in 2009. We started it in 2010. We have mature data in 2022. The really good news is that our triplet therapies have now been added to by what we call quadruplets, with the integration of monoclonal antibodies and next-generation novel therapies. And these results from these studies are extremely exciting and promising, and we've heard some of that data at this meeting. And by virtue of that, this, I think, therefore informs our decision-making even more with the value of certain research tools, such as MRD, providing us with additional guidance as to what best choices there may be for patients. And I want to thank you very much for your attention.
Thank you, Dr. Richardson. We know that the prognosis for multiple myeloma has improved substantially over the past 10 years. I think something very striking here is looking at reporting the progression-free and overall survival. It's multiple years, not just months, as we see with a lot of disease types. And so we think about this trial starting, you said, I think, 2009, 2010, takes this long to get results. We need to invest in this, but standard of care does change. So I think this trial gives very important information related to the benefit and the toxicity so we can have informed discussions with patients. I do think duration of response matters to a lot of patients. We would much rather, some would much rather go a long time. Others would prefer to put off a very toxic treatment like an autologous stem cell transplant until they might need it later. So it offers information that informs a discussion with the patient, and it helps patients make informed choices. So overall survival is not different. I think 28%, I think, of the patients that had the delayed transplant or the stem cell collection without transplant have gone on to get a transplant. The remainder have not. I also think locking in the benefit of the maintenance lenalidomide is an important concept here as well. So major improvements in a disease that has a very long survival, but these patients are alive generally with disease, not cured of their disease. And we want to give them the best quality of life for as long as possible. I think it's time to take questions from the audience. And I have a couple coming in from online. If you're asking a question via the online chat, be sure to include the name, your name, the name of the media outlet, and to whom you're directing your question in the chat. If you're in the room and have a question, please step up to the microphone here and state your name, organization, and who you're directing your question to. So I have, first I'll start with an online question, and this is from Lynn Lederman, writing for Doximity OpDoc, and it's a question for Dr. Richardson. And it's interesting, it's cut off here. Are there predictive markers for the development of MRD negativity that could be, and for some reason I can't see the whole question. So I'll start with, are there predictive markers for the development of MRD negativity that could be used potentially to influence the timing of the transplant?
It's a great question. And essentially what we saw in our study was variance in that, in fact. We saw MRD that was rapid in terms of its documentation and confirmation. And conversely, what we know from our study and others is that MRD negativity can be generated over time. So therefore, you have to be sort of patient, if you will, to see your MRD negativity, particularly with continuous therapy. That being said, there were subgroups in our study who clearly enjoyed great benefit from early transplant in terms of progression-free survival versus others who did not. One very interesting observation we had the highest participation of African American patients in our study of any phase 3 to date in myeloma, approximately 20%. And fascinatingly, in that patient population, the hazard ratio in favor of transplant was around 1. Suggesting that in that particular population, recognizing complete access, there was no issues of that as a question. Pathobiologically, there may be something there, and that was very hypothesis generating. We also saw differences in cytogenetics, certain groups clearly benefiting from transplant, others not. So there were a number of, I think, hypothesis-forming subgroup analyses that really we will present at the meeting this afternoon. But in a nutshell, clearly one size does not fit all.
And understanding that difference in outcome based on race is something we're really going to need to investigate further.
Yes, absolutely.
Thank you. We'll have a question at the microphone.
Excuse me, Caroline Helwig, the ASCO, Dr. Richardson. Since daratumumab is not obviously used for induction, and a trial today would probably include an antibody. So
yes.
Do you have a guess as to whether that would close that 2-year gap in PFS?
Yeah, that's a super question, and thank you for asking it. You know, frankly, we have data from various exploratory studies pointing to just that. Probably one of the most informative actually comes from Shanu's institution, a memorial led by Dr. Ola Landgren, the so-called Manhattan study. And in this study, Ola and his investigators evaluated KRD plus daratumumab and generated an over 70% MRD rate without transplant. So this was a very important phase 2. It was published in JAMA Oncology last year, in fact. Now, obviously, it's a single-arm phase 2, so the usual caveats, but well-sized. So I think we've got some clues as to where we're going. We also have our own work, RVD-Dara plus transplant, led by my colleague Peter Voorhees from, again, the Alliance. And we showed that with transplant, and RVD-Dara, we see the best outcomes. The interesting question is the MRD rates are quite comparable between, for example, Ola's Manhattan study and Peter's RVD-Dara study plus transplant. So a huge question then is, by those 4 drugs, do we start to close the gap? And I can't answer that definitively, but we have clear clues. And if we flip to non-Hodgkin's lymphoma, B-cell, diffuse large B-cell lymphoma, CHOP Rituxan is the quadruplet with transplant kept in reserve now. Our lymphoma colleagues have been way ahead of us in that regard. Whether that will translate into myeloma, we will see. But nonetheless, the addition of the monoclonals, I think, further changes the treatment paradigm.
Okay, thank you. And Dr. Yoshino, too. And also Dr. Ng. I'm looking back at the CALGB 80405 study with cetuximab, which didn't show any difference versus Bev, although it was better in left-sided. But you had 8 months more PFS with panitumumab. So I'm wondering, is this drug just better than cetuximab, or was it a difference in the trial design, or what's your thinking? And Dr. Ng also.
Okay, thank you very much. Excellent question. I guess you mentioned about the discrimination difference of the cetuximab and the panitumumab. I think, in my understanding.
Yeah,
but
are they different?
I think that the previous study comparing the panitumumab with cetuximab monotherapy in the surveillance setting, the very similar outcome. So I still believe that this incorporation of the clinical practice changing from this study is that the anti-EGFR antibody itself, either cetuximab or panitumumab, is that the new standard of care over the bevacizumab. So still, I believe the bevacizumab, cetuximab and panitumumab is interchangeable in my opinion.
Interchangeable, you still say so. Do you agree, Dr. Ng?
I would agree as well. I mean, the data suggests that from all prior studies, they're fairly equivalent. Obviously, higher risk of allergic hypersensitivity reaction with cetuximab, but overall, in regards to overall benefit for the patient, they're equivalent. I think it's based upon the study design. The current study paradigm is based upon the foundation that FIRE 3 also provided information to us about left-sided versus right-sided.
Right.
And so that's just really expanding upon this further in a prospective analysis.
Okay, thank you.
Dr. Ng, do you want to talk a little bit about the difference between left and right-sided colon cancers?
Yeah, so just to make sure everyone is familiar with the literature. So if you look back at 80405, which was the largest study, randomized study that took over 10 years in the United States, we learned that left-sided versus right-sided tumors fare better overall in regards to survival. And in fact, what we also learned is that for right-sided tumors, we do not want to provide anti-EGFR therapy. We've also learned embryologically that they come from different, their origin is different, and that may account for it, but not for all the reasons that we are fully aware of. We do believe that there's some interest in microbiome and et cetera, but we do know that left-sided tumors fare better overall, and the data from 80405 and FIRE 3 and some meta-analyses that have been completed demonstrated that left-sided tumors appear to fare better with the use of anti-EGFR therapy. But the original studies were not powered specifically for that, so that's why this trial is of specific interest, because it is a prospective analysis.
Thank you. We have a question from Jim Kling from MD Edge Oncology, and it's directed to Dr. Modi. How is low HER2 expression defined, and how will that translate to the clinic? Is the definition likely to be fluid? So that's part one. And Jim, if you're online, your second question got cut off, so maybe if you could put that in another box. We'll have her answer the first question, and then we'll get to the second question.
Right. So we defined HER2-low breast cancer using readily available IHC testing, and defined it as cancers with 1+ HER2 expression or 2+ HER2 expression and non-amplification of the gene. So, I mean, these are standard testing technologies that we use in pathology and analysis of breast cancer patients. So the testing is widely available, and it's familiar to most of us. And that is probably the most conventional way of defining HER2-low breast cancer today.
Thanks. A question for you and Dr. Meisel. About other HER2-targeted agents in this population. Has that been studied previously? For example, trastuzumab inhalation.
I mean, the frustration has been that a lot of our current available HER2-targeted therapies, like trastuzumab, have not been effective for this group of patients, where we know where their cancers express this low level of HER2, and we haven't been able to capitalize on that with HER2-targeted therapies up until, trastuzumab deruxtecan, this new generation of antibody-drug conjugates. So, there was one very large adjuvant study, the NSABP B47, where they looked at this population, the HER2-low breast cancer patients. Now, this was an early-stage study. And they looked at adding 1 year of trastuzumab to chemotherapy in a randomized fashion, and found no benefit for the HER2-low patients. And in some smaller, subgroup analyses and other trials of HER2-targeted agents like TDM1, which is another HER2 antibody-drug conjugate, it really is the prototype in breast cancer, and unfortunately it too did not show convincing activity for the HER2 low population. So we haven't had targeted therapy for this group of patients, which is a large subgroup of patients, and so we've sort of been relegated to treating them as if they are HER2 negative. And so I think that's why this data is so significant, because it's the first time we're going to be able to extend HER2 targeted therapy to a new population of breast cancer patients.
Yeah, no, I don't have a whole lot to add to that. I think that's exactly right. And it's, these antibody drug conjugates with some of the new features, in particular with this drug, the high drug to antibody ratio, the bystander effect that you discussed. I think these are some of the unique things that make it particularly useful in this HER2 low population, but it really will cause us to kind of redefine that. And I think as we start to think about HER2 expression in other cancers too, this could have wider implications throughout the cancer community.
So it sounds clear that this result is specific to one antibody drug conjugate targeting HER2. We can't now assume that the whole class of HER2 therapies benefit this population. The follow-up question from Jim was, why do you think this antibody drug conjugate worked while other anti-HER2 approaches didn't?
Yeah, I mean that's a good question, and I think it really does. You're right. This is a specific therapy. Although I will say there are a number of other antibody drug conjugates in development targeting this population as well, and showing promise in their early phase studies as well. So it's really exciting. And I think it really is the benefit we're seeing really relates to the uniqueness of trastuzumab deruxtecan, which I keep calling a new generation antibody drug conjugate. That's because it does have some advanced, I think, pharmaceutical properties compared to our other HER2 therapies in general, not just antibody drug conjugates. And probably the most unique thing, I think Jane was mentioning the high payload that's linked to each antibody in this drug. It's twice as much, for example, as TDM1. The payload itself is very unique. It's novel. It's a topo-1 inhibitor. That's not a kind of chemo we often use in breast cancer. And probably most significantly is the linker payload technology. This is very different than TDM1, for example, and this is a cleavable linker, so this has a lot to do with the technology of this ADC. When that linker is cleaved, it releases the chemotherapy payload in a way that chemo retains membrane permeability. And now it can pass through the HER2 positive cell and enter the microenvironment, and has the ability now to penetrate other cells in the neighboring area that may not even express HER2, frankly. So it offers a broader range of activity in heterogeneous situations, and we know breast cancer is HER2 expression is very heterogeneous. So I think that's why, for the first time, that we're seeing activity for a targeted agent.
Thank you. Question at the microphone.
Hi, I'm Peggy Peck. I'm with Breaking Med, and I have a question for Dr. Modi, but first of all for Dr. Meisel. In your comment, I was very struck by the phrasing that you used, that the cancer just melts away, which I put in capital so when I was taking notes, because frankly I find that to be like, that's sort of like a headline. To me, it's the kind of comment that maybe might overstate, that is really a wow comment, and I'd like you just to how strongly do you feel about using that? I'm thinking about the patients and how they might react, or clinicians, community, oncologists, and how they might react to the use of that.
Yeah, I mean, I think I want to certainly use that with caution. I guess I would say, of course, not every cancer melts away when you use this drug. But I think we have seen, in our HER2 positive patients, as we've used this drug in the clinic, that there are a number of patients, even heavily pretreated patients, who have not responded to other things but have a high burden of systemic disease, and it does start to respond very quickly and very significantly to this agent. Mm-hmm. So I think there is, for all the reasons that Dr. Modi talked about, just a lot of promising things about this agent that allow people to respond when they haven't responded before in the HER2 positive setting. And then what we're seeing in this HER2 low space is that, in fact, these patients may respond as well with the progression-free survival and overall survival improved. Mm-hmm. So I think certainly a promising option for patients. Mm-hmm. In terms of the melting away, I guess I would, again, use that with caution, because it's not something that's going to happen for every patient, and I wouldn't want to create false hope. But it is something that, that we have seen in instances, and that does make us hopeful as clinicians and as researchers for, what the future holds for this drug and for others like it.
Mm-hmm. And Dr. Modi, I would just like you to a little bit more about the lung toxicity, if you could just a little bit more depth on that.
Yeah, I mean, I obviously this is an important toxicity of TDXD. We've seen it in all the trials, and I mean, it was really great, for example, yesterday to see the update from the DESTINY-Breast03 trial, another big randomized study in the metastatic setting where they're continuing to show, the same rate. I mean, we're seeing about a 10 to 12% incidence of lung toxicity. For most patients, thankfully, it's low grade and reversible, but there's a small group of patients where we see high-grade events. And so I was referring to DESTINY-3 because they have shown in this very large study no high-grade events. So that is a great bar and something we strive for in all of our studies. In DESTINY-4, we did see a low rate of grade 5 events, unfortunately. But I think that we have to acknowledge that this is a toxicity of this drug. The question is, we want to be able to use this extremely compelling and efficacious therapy for our patients as safely as we can. From my perspective, the way we do that is to select the right patients and follow, know how to manage ILD. And there are guidelines out there for clinicians. There's been a massive education campaign geared towards clinicians, but also patients about the lung toxicity, to try and educate and give them the tools to be able to manage patients safely. And, I do believe that's had an impact. I mean, if we look at our earliest experience with trastuzumab deruxtecan in breast cancer, and I'm referring to the DESTINY-Breast01 trial, I mean, the grade 5 rate in that study was 2.7%. And now fast forward to the present time where we have a heightened awareness, we have guidelines and tools at our disposal. And in the two most recent studies in breast cancer, the grade 5 rate is 0% to 0.8%. So we really have brought the high grade event rate down, and we should continue to do that, which means we continue the campaign of awareness and giving clinicians the tools and the education they need to manage the patients appropriately.
I think we were much more concerned about the interstitial lung disease when it was first approved in the HER2 setting, which also happened to coincide with the early part of our COVID pandemic when we didn't have vaccines and treatments. And so we weren't sure if we were seeing some pulmonary symptoms, what it was. The drug has been in use now for a couple of years, and I think we have all gotten more comfortable with, first of all, responding to pulmonary symptoms quickly, but also how to manage it. So I think it was much more of a concern a couple of years ago, and now I think we've learned how to be aware and react quickly. So we have another question at the mic.
Hi, Elizabeth Heller, Onc Data Advisor. This is a question for Dr. Modi and Dr. Meisel. So I was interested here, I mean, the results are amazing and the progression-free survival seems to be good for HER2 positive, HER2 low, and you also showed data that HER2 negative had some activity. So how do you reconcile this with it being a targeted therapy?
So I mean, that's a good question. I just want to be clear, we've shown activity in HER2 positive in the past, and in this study we've shown it in HER2 low. This study is restricted to patients with 1+, 2+ expression, not 0 expression, so not the patients who don't have some defined target. So we do believe this is a targeted therapy directed to at least some level of HER2 expression. The actual threshold of HER2 expression, I don't think we have fully defined, and maybe you're referring to the results of the DAISY trial where they saw activity. It's a really interesting study, a great translational study, where they did see evidence of activity in IHC 0 patients. And that was really provocative, but I think one of the things that needs to be made clear is even when we say a tumor has IHC 0 expression, it does not mean there is an absence of HER2 expression. There is still target. In fact, the definition of IHC 0 is that less than 10% of cells have some staining. And so I think what we're learning is that IHC is probably not a sufficient test to really define the lower boundary of HER2 low. There's a lot of efforts underway to try and develop better tests than IHC, including quantitative tests of HER2 expression, incorporating AI technology. And I think so for the future, for me, it's only a positive, because we may be able to expand this therapy to even a larger pool of
No, that's
breast
what
patients.
I thought. I thought you showed a subgroup analysis where they were defined as HER2 negative, and the drug still had this similar benefit for progression-free survival.
Yeah. The HER2 low, and maybe I wasn't clear, HER2 low is a subgroup within HER2 negative.
Got it. Okay, thank you.
So I think, the idea that what was previously defined as HER2 negative is probably not that simple, because HER2 2+ and 1+ before this study really were kind of grouped with the HER2 0 patients into this HER2 negative category if they didn't have amplification of the gene. And now what we're seeing is that the 1+ and 2+ patients actually respond to this targeted therapy because of some of those unique properties. So kind of, just redefining what does HER2 negative really mean. There's, this HER2 low space where now we have a targeted agent potentially.
So to put this in perspective, of those breast cancer patients who we previously called HER2 positive, which meant IHC 3+ or FISH positive, that represented about 20 to 25% of breast cancer. So we had a remaining 75 to 80% we previously called HER2 negative. Of those, IHC could be 0, 1+, or 2+, and at the 2+, we would do FISH, and the FISH would be negative. Of those that we used to call HER2 negative, I think that's almost half of those who now we would call HER2 low. Right. Is that correct?
Yeah, I think in the one of the papers from Alex Pratt's group, they identify. There's problems with this very strict definition, frankly, at this point, or a point estimate for what that percentage population is. But in their sort of clinical pathological study of over 3,600 cases, again, selection bias and testing bias and notwithstanding, it was about 60%, and so I think the statistic we've seen generally is between, around 50%, 50, 60% of breast cancers are HER2 low.
Thanks. I'll go back to an online question. We have Crystal Fenn for Breaking Med, and this is for Dr. Eng. Should these findings from the Paradigm trial largely be applied clinically for left-sided tumors?
That is the expectation following these results being discussed later on at the plenary session. I presume that it will largely validate the role of anti-EGFR therapy in left-sided tumors. Challenge patients who always want to get started on treatment immediately. We will need to obviously wait for the RAS testing to be completed, but it doesn't mean that you can't start the patient on a single cycle of chemotherapy if needed, if they have a left-sided tumor.
Great. And Dr. Richardson, you have a healthy 50-year-old with multiple myeloma. What are you going to say in clinic based on the results of this trial in terms of the timing of the transplant? What are you going to recommend?
Well, yes, I think that there's obviously the data support choice and they support tailoring treatment. And I think we just have to be very clear about high-dose melphalan is phenylalanine mustard. That is soluble mustard gas. That's where it came from. It importantly targets stemness in myeloma. So it's a great drug, and importantly, we need to be thinking to the future, in my view, as to how we can better deploy it, because I didn't show the actual numbers, and I'll show those this afternoon, but in Arm B, we had 10 cases of AML-MDS. We had 0 in the delayed transplant arm. If you're living 20 years with myeloma, that matters. So I think you sit with a 50-year-old and say, look, you've got choices. We can start you on a very active quadrat, a fabulous response, and you achieve MRD negativity. We can harvest your stem cells, and to use an old-fashioned term, keep your powder dry in terms of the autologous transplant. But I do not in any way wish to underestimate the meaningfulness of a substantial PFS benefit of the magnitude we saw. That's dramatic. I think it takes me back to my breast cancer days. What I'm fascinated by is that we saw such a big PFS benefit, but we didn't see an OS benefit. That, back in the days of breast cancer transplant, was considered very important to understand why. And I think as we think about myeloma, obviously a very different disease, but you have to think then, are there pros and are there cons to what we're doing with high-dose melphalan?
Thank you. So one last question online, and then we'll do one last question at the microphone. And this is going from Amy Brown. Dr. Meisel on DB04, Amy's from Evaluate Vantage. Are you confident that the TDXD is having a real benefit in triple-negative patients?
You know, it's a tough question because it was a very small group of triple-negative patients that was evaluated in this trial compared to the hormone receptor-positive patients. You know, I think the mechanism makes sense, and the patients with triple-negative, even though it was a small group, did seem to have benefit over chemotherapy, physician's choice in this study. And so I think, you know, for a HER2-low triple-negative patient where we know the response to, you know, later lines of chemotherapy is going to be a relatively slim benefit, and this drug, even though it's a small subgroup, does seem to offer more benefit. And I think we have biological plausibility and lots of reasons to think it actually works. I think it is something I would reasonably discuss with my patient and try. I mean, I think one of the things this trial does, you know, or will do for these patients is offer another choice and another option. So I think it would be something to reasonably consider, even though it's a small group.
Thanks. And last question.
Lynn Peterson with Trends in Medicine. So Dr. Modi, could you just put in a big, expansive way, what % of all patients are on TDX, and how would this change?
So, I mean, that's a difficult question to answer. We're using trastuzumab deruxtecan in the HER2-positive patients already. So what I would say is that about 50% of breast cancer is HER2-low. And so that is a group that now has a potential to use and benefit from this therapy.
So 60 to 70% of all breast cancer now has data. If we take the 20 to 25% that are 3+, and then, yeah. So more than half of breast cancer has the potential. And we're excited to see the full presentations of all of these abstracts upcoming at the plenary session this afternoon. If you have additional questions and are unable to catch any of the authors after the briefing, ASCO staff will be happy to help arrange an interview for you. And this concludes today's press briefing. Thank you to everyone on the panel. Congratulations on the important work, and we'll see you at the plenary session.